Hi, everyone. My name is Casey Pender, and I'm the National Coordinator for Programs here at ALF. And I'd like to be the first to thank you for joining us today for our Life with Biliary Atresia and Beyond webinar series. I would like to introduce you to our National Director of Community Impact, Ivory Allison, who will say a few words about our new Pediatric Info Center.
Thank you so much, Casey. Welcome, everyone. Our Pediatric Liver Information Center kicked off on February 28th on Rare Disease Day, and we are beyond thrilled for this new site that was sponsored by Albireo. It has 4 sections, one for parents, one for teens and young adults, and one for kids, and then one for the general audience. Our kids section is pretty great for you parents who are always busy, but we have a section that you can print out a coloring book, but the coloring book allows you to educate the kids on their liver, which is amazing. We have a section for a word puzzle so they can learn a little bit about their liver, as well as having a little fun. We also have a wonderful new animated video that we just launched last month for kids, as well as an animated video for adults to just give them a little bit of information on liver disease and what they're going through. So please make sure to check out our website if you haven't, liverfoundation.org, and you can go to Pediatric Information Center to find out more information, and let us know if there's anything on there that you don't see and you feel that we need to add. So thank you, Casey.
Of course. So today's Life with BA and Beyond webinar series is being delivered on Zoom and will be recorded. We really appreciate it if you can mute yourself during the program to avoid any disruptions while our speaker presents today. And if you do have something you want to share or have a question, please utilize the Zoom chat feature or raise your hand and share your thoughts that way. Again, please note that this is being recorded and will be shared with ALF's Life with Biliary Atresia and Beyond Facebook group and our YouTube channel for folks who might not be able to join us live. So if you would like to keep your camera off, please turn it off now. I would now like to introduce you to our featured speaker, Dr. William Balistreri. Through over 600 publications, Dr. B has helped identify causes of liver and gastrointestinal diseases in children, along with ways in which to manage it. His innovative research has addressed many aspects of hepatobiliary biliary diseases in children, including neonatal cholestasis, bile acid metabolism, metabolic liver disease, viral hepatitis, and liver transplantation. For more information on Dr. B, we're going to share a link in our Zoom so you can learn more about him there. Dr. B, thank you for giving us your time today, and I'll now hand things over to you.
Well, thank you very much, Casey and Ivory, for not only the invitation, but for focusing on biliary atresia, something that has been of interest to us for many, many years. So let's start with what we know, that we all know here, and that is this disease is still enigmatic, but there are new insights. And prior to the hepatoportoenterostomy, or the Kasai procedure in the late 50s, this disease was uniformly fatal. But with that procedure, combined often with liver transplant, the outcomes have been improved. Even with the Kasai, the long-term native liver survival is about 20 to 35%. But more importantly, survival rates post-liver transplant are very high. And that brings us to another issue, and that is with survival into adulthood, we need collaborative transition. That's going to be the key. We go from family-centered pediatric care to patient-centered adult care.
Excuse me for just 1 second, Dr. B. Your screen is not being shared.
Okay. How is that?
Perfect. Thank you.
All right. So let's start with what we know, and that is the key factor is one major modifiable factor, and that's the age at initial operation. And you're going to hear that several times throughout this talk. Let me give you 2 examples. Patients here at Cincinnati Children's, Adam and Beth, aliases, of course. Adam on the left and Beth on the right. Adam is alive with his native liver at 32 years of age, whereas Beth needed a transplant at 9 months. So what's the difference between these two? Well, both were healthy, full-term infants. Both were noted by their mother to be persistently jaundiced. Both had pale stools. But Adam was seen at 24 days of age. And on exam, he certainly had liver disease. He had an enlarged liver and spleen. He had elevated liver enzymes. And his conjugated bilirubin, or direct bilirubin, was 4.8, significantly elevated. We did a biopsy, and he was shown to have biliary atresia, and he had the Kasai at 4 weeks of age. Whereas Beth was first seen for a well baby check early in life, and was noted to have elevated liver enzymes. They only measured total bilirubin and was said to have breast milk jaundice. She was not seen again until 4 months of age, when continued abnormalities in the liver tests. She had a small gallbladder on ultrasound, and by biopsy, she had cirrhosis, and then needed a transplant at 9 months of age. So that's the major battle that we fight, and that is early recognition of this disease. So I'll go through that, defining the disease, talk about recognition, talk about the cause, and then management and outcomes. First, what is the definition? Well, you probably already know this, but let me start with basic principles. The liver is drained by a series of bile ducts, those in the liver, intrahepatic, and those extrahepatic. And the extrahepatic ducts are meant to drain into the duodenum, clearing them out of the liver, all constituents, and also providing material to absorb fat and fat-soluble vitamins. Biliary atresia is the end result of progressive scarring and inflammation of those bile ducts at any level, from inside the liver all the way to their entry into the duodenum. That leads to obliteration of the bile ducts. One of my patients best described it as, you mean it was once a straw and now it's a twine. And I think that really describes it very well. In other words, it's obstruction to bile flow. You can't move through the straw. Here's a couple of pictures, at least in cross section. So if we made a cut through here and looked at the cross section, you'd see a fairly normal bile duct surrounded by tissue. This is the lumen in which bile is meant to drain. But in patients with biliary atresia, that same cross-section would show that the bile duct is now filled with scar tissue. The lumen or duct is obliterated. Now, biliary atresia is classified in several manners. This is the most common classification, 3 sets. One in which the atretic segment or fibrotic blocked segment is the distal common bile duct. Another in which the segment is simply the common hepatic duct, or both the common hepatic duct and the gallbladder, cystic duct. But unfortunately, the most common is where the entire extrahepatic bile duct is obstructed. That's the problem that we face. Now, the good news is prompt surgical intervention may restore bile drainage, but progressive intrahepatic disease results. And biliary atresia is the #1 indication for liver transplant in the pediatric population. Now, when I say biliary atresia, it's not one disease. I think many would believe that. It's like an animal. You say animal, it can mean many things. There are multiple phenotypes. Phenotypes, in other words, observable characteristics. There are at least 5 different varieties, and we'll talk about 2, isolated and what's called the bile acid splenic malformation variant. Now, these variants may have different causes, and they certainly will have a different clinical course and response to the Kasai. So let's start with the most common, the isolated form. That's about 80% of these patients, similar to what we saw with patient Adam. Jaundice, normal growth early on, but then progressive. The other variety is a malformation variety. In other words, the duct may have been malformed earlier in life, maybe even in utero. and it's associated with non-hepatic malformations, the spleen, the heart, and so on. And that is called biliary atresia, splenic malformation. That accounts for about 15, maybe even up to 20%, BASM. It's associated with polysplenia, so you or your child may have been diagnosed with polysplenia syndrome with biliary atresia. The theory has been that the isolated form is destruction of already fully formed bile ducts that then are progressively obliterated, whereas the malformation form is a defect in bile duct formation, perhaps a major gene mutation. However, the actual causes is probably much more complex, as you'll hear. So how do we diagnose? And how common is it? Well, first of all, it is a rare disease, but still, it's about 1 in 10,000 live births. Seems a little bit more common in girls and maybe in certain populations, but it is still the most chronic liver disease in children. Now, the interesting factor of epidemiology is it is discordant in twins. One twin has it, the other, even identical twins in many cases, does not have it, which raises the enigma even deeper, more of a conundrum to us. I mentioned our goal is to recognize promptly because fibrosis develops very rapidly. So any delay in evaluation or surgery must be avoided. And here's a great example. This is a graph of the age up to 90 days of age and the degree of liver stiffness, in other words, the degree of scarring. And you can see how rapidly, even in the first 30, 40, 50 days of life, that scarring occurs. So we need to intervene. Now, in defense of primary care, cholestasis may not be obvious because it does overlap with breast milk jaundice, and that certainly happened with our patient Beth. However, in patients with biliary atresia, the jaundice will persist, and the mothers and fathers persist in bringing that to the attention with dark urine and pale stools. Now, in terms of workup, no single test is discriminatory. But I'll emphasize once again, you need to first recognize that this is cholestasis. And that's done by fractionating serum bilirubin. That's the key. And then they are referred for evaluation. And once they are brought to us for evaluation, we carry out a stepwise evaluation with the end result to confirm biliary atresia. The number of maneuvers we do, certainly clinical exam, history and physical, make sure we know what the liver synthetic function is, repeat the bilirubin conjugated or direct, they're the same basically. We measure serum bile acids, and then we rely on ultrasound and liver biopsy. An ultrasound, even in utero, can often be quite helpful, especially if it shows an absent gallbladder or difficulty visualizing the common bile duct. So that is often our first clue. We then do a liver biopsy in almost all of these patients. And even early on, you can see that bile, as stuck in this intrahepatic bile duct, is not draining out of the liver. And that's a real clue for us. And you again can see with biopsies 4, 6, 7, and 8 weeks, how rapidly that scarring will accumulate. And not just in the liver, but the bile ducts, as I already showed you, are rapidly and progressively obliterated. This is a patient that at 4 weeks had a normal bile duct lumen, but by 8 weeks that had been obliterated. So we have a very short window in which to operate. That is our major modifiable factor. And we've made the plea for many years to try to establish the diagnosis as early as possible with a goal before 30 days of life. But we failed miserably because even with massive education efforts by the American Liver Foundation, ASLD, and others, the average age at diagnosis is still 65 to 70 days. So we need a reliable, cost-effective screening method. The AAP, American Academy, recommends that bilirubin be fractionated if the jaundice persists after 2 weeks of age. So that's something that parents can continue to help us with. The problem is infant wellness visits are seen, the babies are seen at about 5 days, a weight check, and then not again until 2 months. So again, that window is rapidly closing. And this shows the incidence of biliary atresia and the timing of the Kasai operation. And since 1997 up to 2009, I'm sure this hasn't changed, the average age remains about 63 days. We must do better. It's not just the United States. Here's a study from France, 1986, 2002, no change at the average age of diagnosis. So we need some population-based screening programs. That would be a great healthcare initiative. So the plea has been to educate and empower not only mothers and fathers, but primary care providers. And that can simply be done. In the United Kingdom, they began what's called the Yellow Alert, an awareness campaign, in which they said any baby jaundiced after 14 days should be evaluated. And they have handouts such as this to give out in the nursery. There have been campaigns here in the United States to educate about fractionating serum bilirubin. And Sonny Harpavath in Denver had a very nice study that showed conjugated or direct bilirubin levels are elevated even shortly after birth. What they did at Texas Children's was they reviewed all the serum bilirubin levels at all newborns at certain birth hospitals. And indeed, direct bilirubin levels were elevated in all 34 of patients with biliary atresia at 24 to 72 hours of life. And you can see the problem. If you just measure total bilirubin, there's not a significant difference. But if you focus on direct or conjugated, biliary atresia is easily recognized. They extended this study to more newborns in a follow-up study. And again, highly sensitive. The sensitivity of the test, 100%, and the specificity, 98%. So that suggests that the initial insult may well be prenatal, and that direct or conjugated bilirubin is a good means of screening for biliary atresia. And that has been validated in prospective studies. 124,000 newborns, they measured a two-step process. Bilirubin measured within 60 hours after birth. And if the bilirubin was above the hospital range, that was a positive screen. They then asked that the bilirubin be repeated at about 2 weeks of age by the primary care provider. And if it was increasing or greater than 1, that's a positive screen for biliary atresia, high sensitivity and specificity. And indeed, when they implemented that screening program, you can see the age at the Kasai dropped from well over 60 days to somewhere in the 30-day range. And indeed, normalization of bilirubin, which is the goal of the Kasai procedure, before screening and after screening implementation. So this works. And indeed, transplant-free survival helped that native liver stay healthy. This has been followed up and implemented in Utah, and they validated that conjugated bilirubins are elevated and would be a great way to screen these babies. Now, stool color is another great way. You know, this is something that anyone can visualize, but even healthcare providers, only 33% correctly identified stool color. So that's difficult. So again, empower the parents. And what's been done is stool cards, saying if your child has a stool color in one of these 3 palettes, please let your primary care provider know. These are normal stool colors. That stool card program has been implemented in Taiwan. Very large number of infants. Biliary atresia was found in 29. And again, you can see high sensitivity, specificity, and most importantly, a negative predictive value. In other words, if the child doesn't have biliary atresia. Using the stool card, the national rate of Kasai went from 47% less than 60 days before to 74%, with no case greater than 90 days. And the jaundice-free rate at 3 months increased from 37% to 60%, so highly successful. And this has been done in other countries, including 2 studies showing high success in Canada. And again, in Japan, same thing. Mean age at Kasai, if the stool card color was used, 59 days versus 68 in non-users. So again, highly predictive. But what about here in the United States? Well, it's been shown over and over again that screening with stool card could be economically feasible. But unfortunately, it's not been implemented for a number of reasons. There are significant requirements, engagement among families, of course, methodology most appropriate to the culture and the region. You need an infrastructure, and most importantly, a process for case follow. So are there other biomarkers? Well, in Cincinnati, we developed a test called MMP7. Dr. Becerra and my colleagues in Cincinnati have developed this test. It is MMP7 is serum metalloproteinase. It's a marker of biliary injury, and it can be easily measured in blood. And you can see that in the first study done by one of our fellows, the level of MMP7 was much higher in patients with biliary atresia versus patients with other forms of cholestasis or normal healthy children. Another study done now in Asia, mean concentration of serum MMP7 in healthy controls was only 3. In other forms of cholestasis, 12. But look at biliary atresia, 120. And so the sensitivity and specificity are sky high, 0.99. Very good test. It was repeated in Japan, same thing. MMP7 is markedly higher in biliary atresia patients than in other forms of cholestasis or in healthy controls. It's now been used on a dried blood spot, which, as you know, is used for many newborn screening programs. And even on a dried blood spot, this test is highly accurate to recognize biliary atresia. Another beauty of that test is it will track progression. So if a patient is surviving with a native liver, the MMP7 will level off and predict a good outcome. Whereas if they are not going to survive with their native liver, the MMP7 will stay elevated. So very, very good test. In fact, we've changed our algorithm for working up patients with biliary atresia. History and physical, standard blood test, ultrasound. We've then added MMP7, and these children may go directly to the operating room for cholangiography, maybe even bypassing liver biopsy, although we still do it. Now, the question is always, what's the cause? There are some clues from the clinical features and pathology and some both animal and human data. One of the biggest clues is what I told you. It doesn't occur in twins, including identical twins. The other clue is the onset. Biliary atresia is a disease of newborns. You don't see it in adults or adolescents or other children. But let's start with what we don't know, and that is I don't have a definitive answer. But with any complex disease, you have to implicate environmental factors, susceptibility factors working together to cause disease. Maybe with other insults, genetic, viral, toxins, or immunologic dysfunction. So this is the potential list of causes. And if this were a multiple choice question, the correct answer of what causes biliary atresia would probably be all of the above. Let me explain. What about a defect in embryogenesis or the development? Well, it's evident at birth, so suggests a developmental abnormality. There are coexisting abnormalities which suggest a genetic defect, but it doesn't recur postoperative. And you have unaffected twins. So that may not be the right answer. So development may play a role in offering susceptibility. What about viruses or toxins or other environmental factors? Well, one of the pros is biliary atresia may be an acquired disease, although that's conjectural. But the con is no viruses have ever been isolated. Now, it's possible that the virus infection is short-lived, thus you can't identify it by the time you see the patient. But that infection leads to an aberrant immune response, which we know occurs. We've learned that from many viruses, including COVID. There are several candidates that have been identified both in human patients as well as in mice models. This is a mouse model used, again, by my colleagues here in Cincinnati, Aki Asai and Georgie Bezea. You can infect a newborn mouse with RRV, a rotavirus, and they will have a time-restricted susceptibility to biliary atresia. The mice will have acolic stools, they will have bile duct proliferation and portal inflammation, model of biliary atresia. What about toxins? Well, again, it's presumably an acquired disease, but again, no toxins have ever been isolated, except in one animal model, and that's some time-space clustering in which cyclic epidemics of biliary atresia occurred in newborn Australian livestock. This was coincident in 3 years with maternal consumption of Dysphaenia plant due to drought conditions. So this group in CHOP imported Dysphaenia from pastures grazed on during that outbreak. And they used a zebrafish model to isolate a novel toxin, a phytosterol, which they named biliary atresia. And when they exposed zebrafish to biliary atresia, it destroyed the extrahepatic bile ducts. And here's some immunofluorescent images. This is normal gallbladder of the zebrafish, and they're excreting the dye into the intestine. Whereas the biliary atresia treated model, no gallbladder and no intestinal excretion. And in fact, on biopsies, as compared to control, where you had a nice bile duct lumen, the biliary atresia treated model had no bile duct lumen. Now, it's interesting, human microbiome, the bugs in our gut, produce a metabolite of soy proteins that's somewhat similar to biliary atresia. So again, if you combine that with genetic susceptibility, does that trigger human biliary atresia? We talked about genetic factors, including susceptibility, and there are pros and cons, which we've talked about. But no definitive gene has ever been identified. In the BASM model, or the malformation model, there is a model, a PKD1L1, which is the first genetic model. So that helps us at least to start to chip away. What about immunologic and dysregulation, autoimmunity, or the abnormal inflammatory response that I talked about? Again, pros, clearly fibroinflammation in the liver. Cytokines, markers of inflammation are present. We have some disease models, but the question is, was biliary tree ever opened and then damaged by inflammation? It would be important to know if anti-inflammatory drugs work, because they are of questionable benefit. So here's the current theory. As I mentioned, it's probably all of the above. You have viruses, you have toxins, you have susceptibility causing bile duct injury. That may be genetically determined in terms of the inflammatory response leading to bile duct obstruction, which is both in the liver and the bile ducts. So our RV model, PKD1L1 model, and biliary atresia all give us clues. My colleagues have put together a review as where we stand. And I think this is probably the best diagram, and that is there's an insult from some environmental factor, a virus or a toxin, triggers that immune response, modified by genetic developmental factors, which cause the phenotype of biliary atresia. So what can we do about biliary atresia? Well, the good news is we can restore bile flow with a Kasai procedure. And that is something that will preserve the liver, at least for a time being. This was devised by Morio Kasai and colleagues, and that's called the hepatoportoenterostomy, or as we call it, the Kasai procedure. And it's a simple idea. If there's no bile ducts coming out of the liver, let's cut into that fibrous area and put a loop of bowel up there to drain the liver. Prior to Kasai, as I mentioned, this was uniformly fatal, but it has improved outcomes with long-term native liver survival of about 20 to 35%. So the next step would be liver transplant to allow 95% survival, because survival rates post-liver transplant are high. These are some of my patients, including one who's both a mother and a nurse, and one who is both a hepatologist and a survivor. But it's a long journey with multiple detours, multiple steps. Many of you have been through it. The first step is to establish the diagnosis and then define the anatomy with a cholangiogram. Here's a normal cholangiogram in which dye is injected, showing the gallbladder and the intrahepatic and extrahepatic bile ducts draining into the duodenum. This is a patient with biliary atresia. The dye is going nowhere. The next step is to construct that portoenterostomy. Our surgeons have become very, very gifted at this. And you may remember last year, Greg Tiao, my surgical colleague, presented a very nice webinar, which is accessible to you if you want to hear the details of the operation. Our philosophy is everyone is a candidate for primary Kasai, but it may not be possible if the patient is of advanced age, like Beth. And that means the liver is hard and firm and they're not going to restore bile. And we can see the degree of fibrosis and inflammation and signs of portal hypertension. My colleagues tell me you have one good shot and you do not reoperate without a specific indication. Now, in some cases, especially those with advanced age, primary liver transplant can be used. It's not an unacceptable alternative. So let's look at the outcomes. This is Dr. Kasai's data. And you can see that over 11 years, a significant number cleared jaundice. But there were some in which jaundice was not cleared, and they either would die or require a liver transplant. There are factors which determine that outcome: the age at operation, the syndromes, the experience and technique of the surgeon, the center effect, the rate of progression of intrahepatic disease, and the prevention of cholangitis, a big issue. So this is Dr. Kasai's data. If he could operate in less than 60 days, he was 91% successful. But if it was delayed beyond 90 days, the success rate was only 17%. This is a more recent follow-up data out to 50 years of some of Dr. Kasai's original patients. The survival rate, if they were operated at less than 60 days, was higher than those who were operated at over 60 days of age, and it did seem to level off. This is data from Canada, very similar. Operate at less than 30 days, a higher probability of survival than over 90 days. And this is a breakdown of a large number of patients from France. Very, very similar data following out to 25 years. Less than 31 days, 38% survival with native liver. Over 90 days, only 19%. Here's a graph in the United States. Survival following Kasai out to 20 years, about 21% survival with native liver. But you can break that down into two different types of outcomes. Number one, these are patients in which the operation is unsuccessful. Persistent jaundice, malnutrition, like Beth, transplanted at 12 to 18 months. And this is a problem because a small baby with median weight of 9 kilos makes the operation a little more difficult. The second are patients who were transplanted at about 10 to 11 years of age. They develop portal hypertension and pulmonary complications. There is the third, of course, the long-term survivors. Outcome of those with their native liver. This is a study from Italy. Consecutive patients after Kasai out to 40 years, 41% at 5, 32% at 10 years, 18% at 20, and 15% at 40 years. Now, most subjects with biliary atresia living with their native liver after 5 years Kasai have some clinical or biochemical evidence of chronic liver disease. And this can be described here again, age on this axis and the percent native liver survival decreasing but leveling off. Those who develop cholangitis as a big risk because that may enhance liver injury. Those who would develop portal hypertension, and the rate of malignancies is real but very, very small. So we need to continue to monitor these individuals. Can you foretell the outcome of long-term survival? Well, there's a number of markers that have been used to gauge transplant-free survival. The most common are serum bilirubin, of course, MMP7, and then these two new markers, which I'll mention to you. This is survival with native liver at 700 days after Kasai for those whose total serum bilirubin was less than 2 compared to those who had persistently elevated serum bilirubin. So that's a good marker. And here's another study, survival with native liver with low total serum bilirubin versus elevated. So that's been a good marker. More recently, this is this year, serum bile acids at 6 months after Kasai will predict native liver survival. If it's less than 40 micromoles, that's pretty much normal. That's a great sign, as opposed to those who had elevated. And then one more marker that was just published, FGF19. If the level is increased at Kasai, that's associated with an unsuccessful outcome. And here's the data. FGF greater, in other words, elevated over 109, native liver survival decreased, whereas those in which at Kasai it was low, they had a better outcome. Is there any way we can help enhance survival with native liver? Well, a number of medications have been utilized, including ursodeoxycholic acid and other bile acid analogs. There's not really clear data on whether they work. But there are investigational drugs, including immune modulating therapies, IVIG and rituximab, antifibrotics, antioxidants, and then 2 new approaches. Let me share some data with you, especially steroids. It makes sense that if there's inflammation and central to the injury, then corticosteroids may help improve the clinical course. But unfortunately, it's still an unresolved issue. This is a study done again, led by my colleague, Georgie Bezea, in which they randomized infants, 140 of them, to either high-dose steroids and versus placebo. This was after the Kasai. And you can see the primary endpoint, survival with native liver. You can see it really was not significantly different. Steroids versus placebos, the main endpoint, no difference. And in fact, those who received placebo had less adverse events. So that sort of put a stop to consideration of steroids in some centers, but other centers have continued, including our own center. We just published this data of tailored therapy after the Kasai. This was published just a month or so ago. And this is a customized use of steroids and antibiotics. We did this in 20 consecutive infants. We monitored them after the Kasai. We looked for inflammation on biopsy. And here's the breakdown. If the stool color was normal, then we would leave conventional therapy. If they were already acolic stools and the age at the Kasai was over 45 days, we would do a biopsy. And if they had inflammation, they would get steroids and antibiotics. And you can see this was successful. 80% who received the steroid antibiotics had successful bile drainage versus 40% in control. 69% were alive with their native liver versus 50% in historical controls. And so this is preliminary, maybe tailored use of steroids. And as I mentioned, there's still conjecture, so stay tuned. 2 new studies, ileal bile acid transport inhibitors. These are clinical trials that are still, the results have not yet been published, but these are drugs that will block bile acid reabsorption. In other words, reduce the bile acid pool size. I'm anxiously awaiting the results of this trial to offer some more hope to our patients. As I mentioned, the next step is transplant, pre and post. Going back to 1983, the same thing that we've talked about, that Kasai should be the primary approach, transplant those who fail, and it should be delayed as long as possible to permit maximum growth. Because this is the problem we face, among others, malnutrition, along with other decompensated functions, recurrent cholangitis, recurrent infection. So we need to guard against that. But as I've already mentioned, if they do reach transplant, survival rates are high. In fact, if you look at the data from the national database, patients with biliary atresia post-transplant do very, very well. In fact, better than fulminant liver disease and some other forms of liver injury. We still have challenges, and this is where we need everyone's help. We need to develop a culture of early recognition, better care transitions, better addressing disparity in access to care. We certainly need to know the cause and therefore develop cures. We've tried to emphasize to primary pediatric healthcare providers that early recognition is optimal. So it should be identified by the time of the first well baby visit. Transitions are a big issue. As I mentioned, biliary atresia, many survive with their native liver, but still have chronic disease. As I mentioned in the beginning, we need to transition from family-centered pediatric care to patient-centered adult care. And unfortunately, that adolescence coincides with a number of biologic events in adolescence: increased non-adherence, shifting responsibilities, parent to caregiver, or ultimately a risk of loss to follow-up. This was a study that looked at patients who died after transplant. Now, the main factors were substance use, diabetes, lack of an education, non-adherence, age at transplant, and of course, there still are social determinants of health. And we need to address that because racial, ethnic minority children have worse outcomes. Disease severity and immediate environmental, socioeconomic factors clearly play integral roles. This was studied from Houston. Non-Hispanic Black and Hispanic infants are more likely to have a delay in referral than white infants. Here's the graph. The percent referred to a specialist. Non-Hispanic white, quite early, and you can see all the other ethnic groups later referred. My colleague Alex Bondoc had this paper published. Our center has noted an increase in the number of underrepresented minority patients referred for evaluation at older ages, which means you can't perform the Kasai. They will have to go right to transplant. So what are we doing? Well, like today and last year with Dr. Tiao, trying to educate quality, and we're conducting quality improvement projects to look at our referral patterns and assess the consequences of delay. Centers must endeavor to recognize and address and mitigate socioeconomic risk factors in order to provide excellent care to all patients. Well, let me end with saying we're going to find a cure, but it's going to take a cooperative multi-center effort, and that is the Children Network is leading the way, doing a great job. Our goal is to save livers and save lives. No question. We still have challenges. Ivory already mentioned, ALF is doing a great job with the Pediatric Information Center and a very nice video for children regarding biliary atresia. So I want to thank you and now open it up to questions and comments and really appreciate the opportunity to share these thoughts with you.
Thank you so much, Dr. B, for that amazing presentation. As just mentioned, we will now introduce our Q&A session. We have some questions from our Facebook group, but we would love to open it up first to everybody here. So Brandon, I see your hand is raised. If you would like to ask your question, you could go ahead now.
Thank you. So thankfully, we actually did learn a lot of that early on. With my son, he was lucky, like he got his split bilirubin and everything pretty much immediately. upon birth. It was part of his first levels, which is the way that his pediatrician noticed that his direct bilirubin was actually going up, instead of just like it randomly appeared. So my other question though is I actually happen to have my yearly physical at about 5 weeks postpartum myself, and then my son was scheduled for the Kasai the following day, or actually the following week, and my liver enzymes were high. So I was wondering if, since it does seem like it's a possibility that it's something that's prenatal or perinatal, would that mean that like the mom's liver is also working somewhat overtime, and can that be an indication as well that there could be something wrong? Like, has anyone looked into that?
Yeah, thank you for the question. That has always been an important consideration, and that is, are there in utero or prenatal events? And there really nothing has been proven, and we certainly don't want to place guilt on parents and mothers. So no, that has never been conclusive.
Thank you. We have some more questions from the chat. One question, what kind of doctor does the Kasai procedure?
Casey, I'm sorry, you're getting a lot of feedback. But I did get the question.
Okay.
What kind of surgeon does the Kasai procedure? Well, it's many centers. In our center, we have 2 pediatric surgeons who do both our Kasai and our transplants, Dr. Tial and Dr. Bondoc, who I've already mentioned. And that's somewhat a similar model in other centers.
Thank you. I'm not sure if my sound is still weird, but we do have some more questions from the chat.
Yeah,
When do you typically?
it's a little echoey, Casey. I'll take it just as a little echoey.
Sure.
But I think the next question is, let me know if I'm correct or not. When do you typically stop the steroid antibiotic protocol once things have leveled out? Are there other meds that are used to prevent cholangitis?
Yeah, that's another great question. We're still working that out. The typical course, as I showed in our study, was brief. Immediately after the Kasai for most patients for a short period of time to prevent cholangitis, and then reinstituted whenever there's a suggestion of cholangitis, which is usually fever and maybe a rise in the level of bilirubin.
Thank you for that question, Leandra. The other question is, how many transplants are needed to last a baby a lifetime, given they are compliant with medications, diet, and lifestyle? And is cholangitis a concern post-transplant as well?
Yeah, well, with luck, you only need it once. The graft survival rates are well above 90%. Some patients may need a second transplant, but that's not very common. And yes, cholangitis is always a consideration anytime the biliary tract has been operated on. So it has to be on the front, the top of your diagnostic differential. Thank you.
No, thank you. Brandy, your hand is raised. I'm not sure if that was from earlier or if you had another question or comment.
Sorry, it was from earlier.
Oh, okay. Okay. Does anyone else have any questions or comments? I think we have one that came in through our Facebook group that said, hopefully I get this correctly. My daughter is 40 years old with BA. She had the Kasai procedure at 6 weeks. I am 67 years old. If my daughter were to require a liver transplant in the future, would I be able to give her a lobe of my liver, or would she require a full liver transplant? And we have the same blood type.
Yeah, well, that's great news that she has reached 40. Obviously, you saw the curves, certainly levels out, but these patients can continue to need monitoring. Now, in terms of adult to adult living related donor, that varies from center to center. So you would need to, if you ever reach that point, that would need to be discussed with your transplant center.
Okay, that's good to know. We'll definitely share that with the Facebook group. The second question is, I am a 42-year-old with my native liver and had the Kasai procedure done at 6 months old. I would love to hear any studies or advice on the management of the disease as an adult.
Yeah, well, again, congratulations. You certainly have defied those odds. And at 45, I think, like any 45-year-old, the goal is to keep your liver healthy. And what keeps livers healthy? Well, we know what makes livers unhealthy: alcohol, obesity, certain drugs, other viruses. So a healthy lifestyle, and enjoy at least another 45 with that liver.
Yes, absolutely. One question is, how long should you wait to bring your child to the hospital if their jaundice persists? I know, Dr. B, we've had some people say that at times with their pediatrician, they've had delayed diagnosis because the doctor would say, oh, it's just a little jaundice, it's no problem. But come to find out it is serious. So what should they do?
Well, Ivory, that's exactly what we're saying. We need to have you as a mother or father are the major advocate. And there's no such thing as a little pregnancy. There's no such thing as a touch of jaundice. It has to be evaluated, period. You need to put your foot down and say, I know that it's uncommon. And in defense of primary care, they may go their entire career and never see a patient with biliary atresia. But if you're a parent and your child is persistently jaundiced, you need to get that bilirubin fractionated. There's no reason.
No, absolutely. Another question was, is there a certain order that your doctor should schedule tests? Example, blood tests first, then ultrasound, etc. What's the process?
No, as I say, I would love a simple fractionation of bilirubin and then have us do the rest, because interpretations of ultrasounds may not, in a hospital or laboratory that's not seen it before, that may be difficult. So my only plea is fractionate that bilirubin, and maybe as we get a better handle on screening, some of the methods I mentioned to you, MMP7, for example, or serum bile acids, FGF19, that'll be incorporated into normal newborn screening. As I mentioned, MMP7 can be done on dry blood spot, which is what they screen all newborns for with the Guthrie test for, galactosemia, tyrosinemia, things of the sort.
Okay. We have a question from Jamie, and I'll read it. And of course, Jamie can jump off if I don't say it correctly, but what are the biggest concerns with babies needing a transplant at such a young age? Her baby is 9 months and we are on the transplant list. He is only 15.5 pounds, and the surgeon did mention something regarding the blood flow being a challenge given his tubes may be much smaller than the transplanted liver tubes.
Yeah, well, I'm not a surgeon, but I play one when I give lectures. Obviously, the larger the blood vessels, the easier the hookup. As simple as that. And our surgeons are used to using microsurgical techniques to do that in anastomosis. So there's no question that in very tiny babies, and we're talking now, 5 kilos, whereas the patient that you mentioned is 15 pounds. So that is a concern, but again, in the proper hands, that can be done.
Okay. Someone wanted to know, could two-step bilirubin screening help diagnose biliary atresia? And are there any other diseases that can be mistaken for biliary atresia?
Oh, great questions. Yeah, that two-step process where you screen everybody, and then if it reaches the cutoff point, then they get back to their primary care within two to 3 weeks. So I'd love to see that instituted more broadly. And the Utah group, as I mentioned, has tried to do this. It's legwork, it's infrastructure, it's funding. So all that, again, we have advocates on the line. All of you are advocates. We need to continue to get that done. I'm sorry, there was a second part to the question also.
Was there a second part?
Yeah, about
Oh, can it be? I think it was the two-step bilirubin, and then are there any other diseases that can be mistaken for BA?
Yeah, I showed you on my slide, when we evaluate, there's a number of diseases that can be mistaken for biliary atresia, and they need to be very carefully evaluated. There's a whole host of diseases called intrahepatic cholestasis, where the extrahepatic bile ducts are totally normal. And there's a host of metabolic diseases, viral disease. So that evaluation not only has to be prompt, but it has to be targeted. And so, yes, another reason these diseases can then be recognized and treated early. Great
Wow.
question.
Thank you so much, Dr. B. If anyone, I don't see any other questions in the chat. We did have a wonderful comment from someone. Just a huge shout out to Dr. B and Cincinnati Children's for their exceptional care of our daughter, transplanted at 6 months. She's 12 and a half now, and we owe her life to those great doctors. So he wanted to shout you out, Dr. B.
Well, thank you. We have a great team, and what you said is what it's all about. You know, we want to save livers and save lives. So we all have work to do. So I appreciate all of you continuing to help in that cause.
No, we thank you so much. And we thank all of you for joining us today for such an informative program, which was so needed. We definitely want to, if you have any additional questions for today's presentation, please continue this conversation in the Facebook group. And if you have specific questions regarding this topic, please send them to us and we can work on getting those answered for you. And we have some upcoming events. On November 30th, we are having a Biliary Atresia Day, which is very exciting, recognition on November 30th at 6 p.m. So you can definitely register for that. We're very excited for that event. And again, join us in our Facebook group. Hopefully all of you are already members. Continue the conversation there and connect with one another.
Well, keep up the great work. American Liver Foundation, you've done a great job. So thank you all. It's been great.
Thank you so much.
You.
No, I think it's been really great, and we are just appreciative of everyone joining us today. This was recorded, and we will be sharing on our YouTube page as well as on our Facebook support group, so you can go back and watch and follow again. So thank you all so very much for joining us.
Bye now.